with social interaction problems, and we found that around 69% had reported some sort of hyperacusis or suffered from hyperacusis. So is hyperacusis and hearing loss related? So they have done a study on many people, and they have figured out that when you look at the data, you don't see a significant relationship between hearing loss and hyperacusis. As I mentioned, many people with hyperacusis, they have close to normal hearing. So yes, it's possible to have hearing loss and hyperacusis, but it is not a common finding for these patients. But tinnitus and hyperacusis go hand to hand. But many people with hyperacusis have reported tinnitus. It ranges from like 40 to 80%, depending on the different studies that we have seen. I always tell my patients around 45% in average, 45 to 50% of patients who have hyperacusis, they also have tinnitus and vice versa. So it is very common to see these two phenomena together, and that's why the treatment of these two is very similar in a sense. We use similar techniques to help these patients, similar, not exactly the same, similar techniques to help them to manage and cope to these conditions. So how does the ear really work? What is the contribution from the ear? And this sensitive system that all of us love and work with it is anything can go wrong in here, and it can result in hyperacusis potentially. Not necessarily a hearing loss, but some sort of damage in here may contribute to hyperacusis and tinnitus. And then when the message is sent to the brain, it can result in multiple types of interpretation of those signals. I want to briefly talk about pain and hyperacusis. We know that there are different types of neurons, the afferent and efferent neurons, that contribute to our sense of hearing. It has been shown that type 2 neurons that innervate outer hair cells, they mediate nociception. That means that they mediate pain. So maybe this is the reason that patients with hyperacusis develop pain also. So these nociceptors that are, we always think about the ear as the place for the processing of sounds, but we know, they have knowledge now that there are some sort of second type 2 neurons, that afferent fibers that provide sense of pain or sense of like other types of somatic senses. So it can be one of the reasons that people perceive pain when they hear a sound. Hyperacusis and noise exposure can be associated. We know that noise exposure can damage structures of the inner ear, maybe it can kill cells. So now that message that goes from the inner ear toward the brain is distorted. So it can result in some sort of sound sensitivity. The phenomenon of central gain that Dr. Salvi from University of Buffalo refers to it is that the central gain, that's why people develop sound sensitivity, because the input from the ear to the brain is distorted. It's like the way that if you do a simple experiment for yourself, if you block your ears for a few days, and when you remove the earplugs from your ears after a few days, now everything, you become sensitive to the sound. That's called a central gain. So why a peripheral problem can result in a central perception? Again, there are a lot of different studies that support a central nervous system problem versus an inner ear problem, but they can go sometimes, the etiology for the hyperacusis can be very wide. But remember the concept of central gain, that the lack of stimulation from peripheral system, it can result in some sort of sound sensitivity in the central nervous system. Sometimes it can be genetic. I mean, some of you have had classes with me on genetics. We know that there are, out of 20,000 genes that we have, around 3,000 of them are related to our communication, to speech, language, and hearing. So there are possibly some genetic contributions also to hyperacusis. We are not sure, but there are some possibilities. So what are these neural correlates of hyperacusis? This fine auditory pathway that we have starts from cochlea all the way to the auditory cortex. They can contribute not only to our hearing, but also they can contribute to hyperacusis and tinnitus. These fibers that leave the cochlea to the lower brainstem at medulla, they go up toward the pons and all the way to the midbrain and the thalamus and the cortex. So any abnormality in these can be associated with hyperacusis. The auditory cortex, the insular cortex, amygdala, the auditory pathway, the non-classical auditory pathway, all of them may have some sort of contributions to hyperacusis. Jastroboffs, Powell, and Margaret, they say that available information suggests that decreased sound tolerance results from dysfunction of the central auditory pathways and their connections with the central nervous system, rather than from dysfunction of the inner ear. So Jastroboffs believe that the problem can be more toward the central nervous system. So there's possibility that some part of the brain is responsible for this. Some sort of distortion in different variety of parts of the brain can be responsible for the problem. Now, how do we know that? They have done fMRI studies, MRI studies, electrophysiological studies to study this. So some scientists worked with Huang, and they identified 3 people with idiopathic hyperacusis. They couldn't find a reason for it. The otological and audiological tests were essentially normal, but patients had sound sensitivity. So when they studied them, they showed some sort of patterns of activity in the frontal lobe and parahippocampal gyri on both sides that can be associated with phobic hypersensitivity to unpleasant sounds. So they contributed activities from the frontal lobe and parahippocampal gyrus. Where is frontal lobe? What does frontal lobe do for us? One of the functions of the frontal lobe is attention. So maybe focusing on a sound resulted in hyperacusis. Parahippocampal gyrus, it's a limbic system structure. Maybe overactivity of that area resulted in limbic system emotional brain function and resulted in hyperacusis. So do not dismiss the contributions from the different parts of the brain with regard to hyperacusis. Another group by Chen, they looked at induction of tinnitus and hyperacusis by using high doses of sodium salicylates as an ototoxic medication to see what kind of effect it will have on the mice when they looked at the blood oxygenation using the fMRIs. So they looked at the activity and they noticed activities, there are areas of the brain, especially at the auditory cortex, showed overactivity to the sound. They also found a branch using these studies, they found a branch that travels from auditory cortex to amygdala. That possibly is the reason for sensitivity of patients to the sound. Amygdala, a limbic system component, is the center for fear and rage. So that annoyance that persons feel from the sound can be because of the activities that we see in amygdala. Effects of medial olivocochlear bundle has been attributed to hyperacusis. The efferent pathway that we have that travels toward the outer hair cells can be related to the impact that is caused by sound and that we perceive as hyperacusis. What they do, we know that the efferent pathway, they modulate the function of the hair cells. So if that pathway is not functioning properly, it can result in some sort of sound sensitivity. So do not forget about the role of the medial olivocochlear, the efferent pathway, and its role on the process of hyperacusis. And I will go back to the efferent pathway when I talk about the autistic children or adults with hyperacusis. Another study looked at the damage to the insular cortex. Insular cortex is a part of the limbic system. So they found patients who had some sort of damage to their insular cortex. These were isolated unilateral insular stroke. The patient had a stroke in that area and developed sound sensitivity. So do not be surprised when you see patients with insular cortex stroke and some sort of sound sensitivity. It is possible. Abnormalities of the MCA, the middle cerebral artery, the aneurysm of that has been associated with hyperacusis in some patients. It seems that the turbulence that it is generated in MCA, in middle cerebral artery, which is very close to the inner ear, that turbulence has generated some sort of sound sensitivity that is perceived in the cochlea by the patient. So be aware that any blood flow abnormalities can be associated with sound sensitivities, which is, we refer to it here as hyperacusis. Hyperacusis and autism have been associated. I mean, we are seeing one of the features. We wrote a paper with Dr. Kaff a few years ago about the hyperacusis and autism, the ASD, autism spectrum disorders. Why children with autism, they cover their ears. I mean, they have oversensitivity to many things, to light, to tactile stimulation, to auditory stimulation. But what is the reason for auditory system? One of the reasons for them to be so sensitive, it can be because of the abnormalities of the efferent pathway. So we did some studies on autistic population when we compared the results of their otoacoustic emissions in patients with ASD and without ASD. We found differences between them in the suppression effect of the efferent pathway when we use contralateral noise. Maybe that pathway is not functioning for them as the way that's supposed to be. So we did some studies at the university for this, and one of the reasons that we started those type of studies, because when we looked at some of the histological studies that was done, it showed some differences in medial superior olive in those with autistic spectrum and with control groups. So there were some differences in the cellular structure of those. So this kind of guided us that if there is a difference in the medial superior olive, which is one of the important nuclei of the central auditory pathway, and it has contributions to the olivocochlear bundle also. So maybe an abnormality in there is the reason that patients show sound sensitivity. So when we studied, we figured out that, you know, there's some sort of contribution to the sound sensitivity through the contralateral suppression of the otoacoustic emissions. So yes, I mean, like, we are not 100% sure. Nothing is perfect in this world, but it can be potentially associated with less activation of the or hypofunction of the medial olivocochlear bundle. We also did a study on the those with Asperger's syndrome that I gave you some introduction earlier, and we looked at it to see that what kind of perceptions they have with regard to the sound, and we recognized that around 69% had a high score in their hyperacusis questionnaires. They had reported that 35% that had tinnitus, and some other findings that we had, but I'm emphasizing on the prevalence of hyperacusis in this population, that a high number of them are suffering from sound sensitivity. And these are lists of publications. Hyperacusis can be associated with Bell's palsy. Bell's palsy is an abnormality of the facial nerve. What does the facial nerve do? Facial nerve sends fibers to the stapedius muscle. What is the function of stapedius muscle? Is to reduce the amount of energy that reaches to the cochlea. So if the stapedius muscle, which is innervated by the facial nerve, is not functioning properly because of the palsy, then the sounds are going to be loud for the person. So hyperacusis can be associated with Bell's palsy at least 30% of the time. So it is one of the findings that I'm sure that you know and you use it in your daily practice. TTTS, the tonic tensor tympani, an abnormality, the fluttering sensations that patients get from the sounds. It can be associated with tinnitus, sound sensitivity, hyperacusis. So do not forget about this condition. That can be one of the contributing factors for hyperacusis. Lyme disease. I have had many patients with Lyme disease. The erythema migrans, this image in here, this is one of the phenotypical features of this condition. And the patients with this Lyme disease, they develop hyperacusis. They're sensitive to sound. Why it is sensitive to sound, we are not sure. Maybe it's an over activity of the central pathway with regard to the sound in this population. But do not forget about asking about history of Lyme disease in the patients that you see with regard to hyperacusis. That's pretty much a common condition. Many of you have encountered patients with an unusual airborne gap, and some of them, they're sensitive to the sound. And when you do order your testings, when you do your audiologic evaluation, when you do your CAT scan studies, you find them that are suffering from a superior canal dehiscence. The amount of sound pressure, the mechanical pressure that is induced to the cochlea via that opening, via that dehiscence, right, sitting under the brain, but by the movement of cerebrospinal fluid can impact or generate a stimulus to the cochlea, especially when there's loud sound. I had a patient who would faint each time when he heard the siren of a fire truck or a police car. So what is the reason for it? It showed that he had superior canal dehiscence. I mean, there are surgical procedures for it, there are rehabilitation procedures for it. So be aware of the possibility of sound sensitivity with these patients also. This is a patient that we saw, and the patient used to faint each time he heard a loud sound. And when we did our studies, pretty much we found a small airborne gap and then an increased amplitude of their CVEMP. So it's one of the procedures that you may want to consider doing for these patients to identify their problem. Another reason for hyperacusis, that is, many people are not aware of it, is the abnormality of the lateral semicircular canal. Lateral semicircular canal dysplasia has been shown to be associated with hyperacusis. We always are concerned about some sort of other reasons, especially the superior canal dehiscence, but do not forget about studying the lateral canal too. The dysplasia of the lateral canal has shown to be associated with hyperacusis, and I'm sure that you can provide excellent type of advice to your colleagues who are dealing with these type of conditions. So do not forget about the lateral semicircular dysplasia that can be associated with hyperacusis. And they have done studies, many studies, and they have shown that the dysplasia of this lateral canal, and they have shown an abnormality of that region that has been associated with hyperacusis. I have a few more minutes. I'm just gonna, for the last few slides, I'd like to talk about some management options. We have written multiple papers with my colleagues from Surrey Hospital, Dr. Hashir Aj, from Dr. Moore from Cambridge University, Dr. Kath from Missouri State. So we have written several articles about the management options for it. One of the recent articles that is available for free online is the cognitive behavioral therapy for tinnitus, hyperacusis, and misophonia. I'm not a psychologist, of course, but there are techniques that you can use in order to help your patients to reduce their emotional reaction to the sound. So there are classes that you can take for CBT for audiologists. There are many articles have been written. So I highly recommend that be very versed with your counseling techniques for vestibular therapy. Oh, I'm sorry, vestibular therapy for cognitive behavioral therapy, because that's one of the most effective and evidence-based approaches that we have right now that can help patients with hyperacusis at the present time. I mean, of course, patients are always looking for a magic pill or quick fix. And that's the thing that I always tell them, I don't have it. I'm sorry, I don't have a magic pill for your condition, for your tinnitus or hyperacusis. But we can retrain your brain, we can rewire your brain, we can educate your brain to be not sensitive to the sounds or your tinnitus. So the CBT basically has a model. And what does it do is basically there are trigger sounds for the person, such as traffic and loud speech for a person with hyperacusis. It generates an emotional response, such as anxiety. People say that I have pain in my ear, I have poor sensation, or like abnormal feelings about the sound. So they generate a lot of thoughts in their head. We call it a negative automatic thoughts, or NATs. And those NATs can basically result in sadness, anxiousness, depression, and all of those. So this circle that you are seeing in here, it can enhance the person's perception for the sound. And our job is to show them that the negative emotional thoughts that they had, most of them can be addressed and examined. And when the patient recognizes that, yes, my pain, for example, that I heard when I heard the sound, or the anxiety that I have, it can be controlled by controlling my emotional reaction to it. Many of them significantly improve. We have also used sound therapy. And sound therapy has been very effective in our treatments. We have introduced sounds at low-level signals, different types of musical sounds, fractal sounds, a modified type of TRT, desensitization with the pleasant sounds, and using signals to introduce gently to the ears at the low level has been shown to be very effective in reducing the patient's reaction to the sound and increasing their tolerance to the sound, and has been very, very helpful. So I do not know where these lines come from. I did not do it. Sorry about that. But in any case, patient education is important. Thanks for removing that. So patient education is important. A lot of people walk around with the earplug in their ears. They have hyperacusis. And using earplugs all the time is one of the reasons that they're not getting better. We always tell them, protect your ears against loud noise. But I don't want you to have this earplugs in your ears all the time, because remember the central gain? So the more they block their ears, the more enhanced would be this perception of the sound when they remove it. So patient education becomes important.
Professor,
yes.
sorry for interruption, but it seems a mistake happened, and we used the free Zoom instead of the paid one. So I'm not sure, maybe the session will end in a few minutes, and
yes.
Some of the participants couldn't be admitted because of this technical problem. Just I wanted to keep you aware. Sorry
Okay,
for that. It's my
sorry about that. But you know, you can extend for another 15, 20 minutes with Zoom. There's an option, I don't know how to do it, but Zoom would allow you to extend to 1 hour at no cost. So if you want to do that, but I'm almost done. Just medications have been used, some anxiety medications, some sort of anticonvulsants have been used. People have tried surgical procedures, such as some sort of stapedectomy to stabilize the stapes have been used. Some people have tried to reinforce the round and oval window by patching them, so not allowing a significant amount of loud sounds enter the inner ear. And the results are controversial. The surgical procedures has been done by kind of patching the round window, and the results, as you can see, I mean, like in average, we have from the loudness discomfort levels, it has dropped to around 10 decibel, but as you can see, it has resulted in more hearing loss. So I'm not sure about how much of this surgical procedures are effective, but again, it is the decision of the clinicians and the patient together to find the right method for the treatment. In any case, I'm just going to summarize. Hyperacusis can come from multiple factors. It is potentially a brain phenomenon. That means that it is processed in the brain. There may be some sorts of psychological components to it, a lot of emotional, limbic system involvement, autonomic nervous system involvement, anxiety and stress associated and depression associated with this, but it's a manageable condition. Again, we don't have a magic pill, but we have ways to help the patients to cope with this condition with the knowledge that we have at this moment. Some other publications that our group has published with regard to hyperacusis: parental mental health is extremely important, so make sure that always you explore the parental mental health. And I'm just gonna stop here. It's around 40 minutes that I have talked. Thank you for your time and attention.
Thank you very much, Professor. It's a really excellent presentation. So let's to first announce that shortly we'll have a master class on tinnitus with Professor Ali Danesh, and we will compensate for the technical issue which happened today by mistake. We used the free Zoom instead of the paid account we have. So any questions? You still hear me, Professor?
Yeah, I can hear you. And
Okay.
yes, I will arrange a mini seminar, like around 2-3 hours sometimes in a month or so we can share with your audience.
Again, Professor, if you can just highlight the difference between recruitment, hyperacusis, and misophonia. We have a question about annoyance from a specific sound from a specific person. And the people asked again to clarify the difference between recruitment and hyperacusis.
Okay, absolutely. I'll be happy to. I hope that our audience are hearing us. In any case, hyperacusis and misophonia. Let's talk about the difference between those two. Hyperacusis, both of them are like some sort of sound sensitivity, decreased sound sensitivity disorder. But hyperacusis is related to the loudness of the sound. Misophonia is related to the content of the sound. So the content of the sound is annoying for a person with misophonia, which is, I wrote a paper recently that was published in Hearing Journal that you can, if you search the Hearing Journal and type misophonia, you can learn about misophonia a little bit more. But misophonia is a condition that is not a matter of loudness, it is a matter of content, such as chewing, such as this clicking sound, such as the high-pitched components of the speech of significant others, such as parents. So these are not related to the loudness of the sound, but the content of the sound. On the other hand, hyperacusis is a condition that is sensitivity to the sounds that are not loud to others, but they're loud to this person. And usually people with hyperacusis, they do not have a significant hearing loss. The difference between hyperacusis and recruitment is that recruitment is a cochlear pathology. Recruitment is a sign of a cochlear lesion that results in an abnormal perception of the loudness of the sound, which happens very quickly, and that's because of the damage in the cochlea. Now, if a person with recruitment starts showing emotional reaction to it, in other words, if a person with recruitment develops sound sensitivity and tries to avoid people, it makes him anxious or it makes her distressed, I call it hyperacusis combined with recruitment. So yes, remember that hyperacusis has a psychological component also to it. So it is possible to see a person with recruitment who developed hyperacusis. They had an underlying pathology that a psychological impact was added to this, and it results in their withdrawal and like dislike of sounds. So there is a kind of similarity between these two, but usually the hyperacusis is not associated with a significant hearing loss. And I hope that answered your question, Dr. Muhammad.
Yeah, perfectly, Professor. Two more questions, Professor. So first question about hyperacusis and migraine. So this is a question. The other question is about if we treat hyperacusis, does tinnitus will improve or no?
Excellent questions. So hyperacusis and migraine, absolutely, they can be associated. So you do it in your case studies. There are some people that were sensitive to light, to sound. So it is possible that it can exacerbate migraine. And treatment of migraine potentially can, with some counseling, potentially can diminish the impact of sound sensitivity, such as hyperacusis. So it's possible, and I'm sure that there is a correlation. I'm sorry, I couldn't hear the person, but in any case, so migraine and hyperacusis can be seen together. That's a very important question. The second question was about that if you treat a person's hyperacusis, can it also treat their tinnitus? Absolutely. In other words, when you address the person's
okay, bro.
When you address a person's tinnitus or hyperacusis, it uses pretty much same principles: involvement of the limbic system, overactivity of the sympathetic system, overactivity of the the person's arousal system with regard to the sound. All of those can be addressed with the use of counseling techniques, CBT, and sound therapy. So definitely they go hand to hand. But the protocols are a little bit different, but they are pretty much using same principles. Any other questions?
A question is asking if hyperacusis is a real entity or a psychological subjective symptom.
Ask your question again, doctor.
Someone, colleague, asking about if hyperacusis is just a psychological and subjective symptom, or it is like a well-identified clinical entity.
Excellent question. Yeah, it is not a psychological disorder. It can be associated with psychological symptoms, but it is not a psychological disorder. And I'll tell you why. Because we have found abnormalities or association in different parts of the brain. I'll give you an example. People with misophonia, which is a class of sound sensitivity disorders, we have been able, studies have shown by Kumar, using, a few years ago, using functional MRIs, they have shown that the triggers that causes misophonic responses are actually processed in the anterior singular gyrus. I'm sorry, the anterior insular cortex, the AIC, the anterior insular cortex. So what does that mean? That means that we have found a specific area in the brain, at least with the current knowledge that we have, that shows this overactivity. We have found using functional MRIs and other electrophysiological tests, we have found portions of the brain that are responsible or contribute to hyperacusis too. So I would consider hyperacusis as a disorder. However, I would also add that this disorder can be associated with psychological problems. It's like any other thing. A patient who suffers from cancer, they may have also a psychological component to it. A patient who has like diabetes and has suffered by it, it may have some sort of life limitations for them that result in a psychological condition. So it is okay to have hyperacusis combined with those features of such as anxiety and stress and distress and depression and all of those. So yes, it can be associated, but it's not a psychiatric or psychological disorder.
One more question, Professor, asking about which questionnaire or assessment tool has been used for hyperacusis?
Beautiful question. The questionnaires that we have are very limited. One of them that is being used is by CALFA. I think it was published in 2002. It is called Hyperacusis Questionnaire. That is very good. Then the modified Hyperacusis Questionnaire has been provided by TPA, the Tinnitus Practitioners Association. Another one is called MASH by Dr. Daumann in France. Another one is a German hyperacusis questionnaire. And finally, recently in 2018, another questionnaire by Dr. Grimberg was published in Ear and Hearing, and Dr. Aj and I have also, with Dr. Moore, have submitted another paper to study the last hyperacusis questionnaire, which is called IHS, the International Inventory for Hyperacusis Scale, and we're hoping that that can be published also. But yes, there are a few questionnaires available that you can use.
We have one more question about misophonia. What is the treatment of misophonia? Is it cognitive behavioral therapy only, or sound therapy can be used?
Another excellent question. The misophonia, remember that our knowledge about misophonia is very limited. I just had a presentation about misophonia. I may share it with you so you can share it with your members.
Thank you.
But misophonia, or if you read the article in Hearing Journal, the number of articles with misophonia that are published in PubMed.gov is less than 100. So our knowledge about misophonia is very limited. However, the treatment options for it include cognitive behavioral therapy and sound therapy, counseling. These are some of the treatments that have shown to be effective in management of misophonia.
We have two more couple of questions. They look
okay.
And I guess we will have double the number of attendee unless I did that mistake and we use the free one. So the first question about what is the role of otoacoustic emission in hyperacusis and tinnitus? Do we expect that is otoacoustic emission will be more robust than the normal or no? This is part of the question. The other part is any rule for the efferent system in hyperacusis? I think they are related. That's why I put together.
Okay, good questions. You have a very active group. Congratulations, Fargal.
No, you attracted the smart people, Professor. That's it.
Okay. All right. So let me tell you about this. Remember that you had a class with me. Remember that I told you that sometimes I have no answer for the questions, which is okay. I mean, I'm not supposed to know everything, but I can tell you about otoacoustic emissions. Otoacoustic emissions are shown to be, our studies showed that otoacoustic emissions had reduced amplitude in autistic population compared to the control group. So the idea of having an increased amplitude for otoacoustic emissions for patients who have hyperacusis, it may not be a true assumption. In other words, having hyperacusis doesn't mean that the outer hair cells are oversensitive or over-functioning. If we believe that the source of responses otoacoustic emissions is purely from the outer hair cells. There's some controversy about it, of course. So what we have is, it is not shown at the present moment, as far as I know, that the amplitude of otoacoustic emissions is larger in patients with hyperacusis. However, it is shown that the function of the olivocochlear bundle, the efferent pathway that innervates the outer hair cells and controls their electromotility, is reduced in those who suffer from hyperacusis, especially in the autistic population. So the current knowledge that we have, again, as far as I know, and there may be future studies or some studies that I have not seen, is that we cannot find a significant difference in the increased function or the SNR of the otoacoustic emissions in the hyperacusis population, and the effect of efferent pathway plays an important role in the process of sound sensitivity. Remember, one of the functions of the efferent pathway is to fine-tune the movement of the hair cells that can help us to understand speech in a background noise. That's one of the features of the outer hair cells that we have. And I think that that's the answer that I have for this question, Dr. Mohammed.
They are perfect, Professor. One more interesting question about the tensor tympani myoclonus syndromes and the hyperacusis and the tinnitus.
So the question is about TTTS,
yes,
and hyperacusis. Yes. So people have looked at this to see what is the reason. Remember, the tensor tympani is innervated by cranial nerve number 5. And cranial nerve, tensor tympani, we are not sure in human that it actually contracts to the sound. We know that the corneal stimulation potentially can contract this, the non-acoustic reflex, in other words, that we can see the contraction of this muscle. We are not sure in human that this reflex that we have, the contraction that we have for the sound, we believe that it is the facial nerve, it is the stapedius muscle, but the tensor tympani, sometimes it can show the fluttering features. that can generate some sort of tinnitus and sound sensitivity. People have used muscle relaxants, flexor, for example, to reduce the response of this. People have tried counseling and CBT to reduce the patient's interaction with regard to the sound sensitivity. People have tried to get into the middle ear and cut the tensor tympani so they won't have that type of problem. So yes, it is possible. It's a rare condition, but it is possible to see the abnormality of tensor tympani that can be associated with sound sensitivity also.
We have a few questions about the treatment. So first question about, you mentioned, but I would like if you highlight this, Professor, the use of earplugs in hyperacusis cases. So we need your comment about this one. Then the other people, they are asking about the other modalities of therapy, like the electrical and magnetic stimulation. If this is has any scientific background, or it is just some sort of business or marketing issues?
Excellent questions again. So I'm going to start with the earplugs. I made this mistake 30 years ago. When I was very young, I had patients who were sensitive to sound. I gave them earplugs. You put it in your ear, it won't be annoying you. Then we recognize that it is not helping patients, putting the earplugs all the time and walking around with them. Why? Because it actually increased their sensitivity to the sound. So smart people came together and said that don't do this. So we do not recommend using earplugs all the time. We recommend using earplugs and ear protection when you go to a noisy place. That's a must. You must do it, everyone. If you have hyperacusis or don't have hyperacusis, because you need to protect, you need to reduce the amount of sound pressure level. You need to protect the amount of sound pressure level that enters your ear canal and reaches to your middle ear and inner ear. So the purpose of using earplugs in noisy places is to reduce the amount of energy that can be damaging to the cochlea. That's a must do for everyone. However, for hyperacusis, if they are annoyed by soft sounds, the soft sounds that is not loud to others, it cannot reach to the cochlea at a level that can damage the cells. Remember, one of the problems that patients with hyperacusis may have is fear. They are worried that they're going to lose their hearing. So that's why that they're using earplugs. So it is important to tell them that it is you protect your ear, but we don't want you to walk around in your daily activities. You're having dinner with your family or listening to a show or something, and you're putting earplugs. For daily conversations, cannot reach to a level that can damage the ear. So you as the clinician, when you counsel these patients, half of them already feel better when they leave your office because you gave them the right advice. Your question about electrical stimulation, remember, yes, electrical stimulation and transcranial magnetic stimulation has been used. There are good procedures. Electrical stimulation goes many, many years back. When Volta found the electric pill, that is like a battery, people start applying those to treat tinnitus. Basically, electric shocks in some patients suppress tinnitus. So electrical stimulation has been used for centuries, 2-3 centuries, to suppress pain, suppress tinnitus, suppress, I don't know, illusions, many things. What we have is that how much effectiveness it has. Electrical pulses have been used. It can be effective. It's been shown like a success rate of 20-30%. I don't remember exact number, but the current evidence-based practice does not completely support use of TENS, transcranial magnetic stimulation, or electrical stimulation for the treatment of tinnitus or hyperacusis. But we are open for this. I mean, if studies show that there are treatments that can use a multi-modality stimulation to treat tinnitus and hyperacusis, I'm for it, and I'll support that. But we need to have more studies to show it, that is effective, and it can be used by clinicians in a safe way, so it can be helpful for patients.
Professor, we have one more question about the difference between misophonia and photophobia. I think it was written photophobia, but I think they mean phonophobia. So
Yes,
what is
yes.
the difference between misophonia and phonophobia?
Excellent. Yes, I'm sure this was phonophobia.
Yes.
So misophonia, it was coined by doctors Margaret and Powell Jasserboff in 2001. Before that, in 1990s, there's an audiologist by name of Dr. Marsha Johnson. She referred to it as S4, which is referred to as, if I remember it correctly, the specific sound sensitivity syndrome, the S4. So they were specifically, these patients were specifically like annoyed by certain sounds. And later on, it was termed, the S4 converted to misophonia, and people used it, and it's a good term. It means hatred of sound, which I don't like to use it that way. I refer to it as dislike of sound. I mean, this is a sound that I don't like to hear, such as the sound of chewing, or sound of gum smacking, or sound of clipping the nail, or sound of a pen clicking. The misophonia is specific to a certain sound. I have treated patients who are sensitive to their mother's S's. The mother time, anytime the mother says spoon or supposed to, that S sound is like an annoying sound to them. It's like a sensation that you get when you have the chalk on the board or nail on the glass. That's the sensation that you get in your guts, that annoyance. That's some sort of sympathetic response that people show to those certain sounds. So the misophonia is a specific sound. But phonophobia is a general term of fear of sound, that any sound is fearful for them. And it stops them from functioning. It can be a more psychologic and psychiatric, can be associated with those conditions. It can be associated with schizophrenia. But phonophobia is the ultimate level of sound sensitivity disorder, that the patient, it just like blocks everything. They put plugs in their ears, they wrap themselves, I don't know, in like blankets, and they want to be in a quiet place because every sound is annoying to them. So phonophobia is more serious than misophonia.
Thank you very much, Professor. I think this is the last question. But I want you just to save my life from much criticism from the audience, that by my mistake, I couldn't allow hundreds other people to join your meeting. And honestly, I didn't expect such interest in hyperacusis and tinnitus. The audience shows a great interest and a very strong knowledge about the two conditions. And I am very pleased to know how much clinicians, especially in our region, they are getting into the interest of these two important points. So my request, my dear professor, just to announce and to ensure them that we be conducting a master class on tinnitus and hyperacusis under your leadership with other international faculties. And for me, Professor, let's to make another session on hyperacusis on the coming master class. But please give them the word from your mouth, so you protect me from much criticism.
Okay. Again, thank you, Arfargal. You're an excellent leader. Thanks again for arranging for this. You have a very good group, and this is an international activity. I know that people from all over the world are listening to this. If you have it ready as a video, maybe you can share it with your audience
Sure.
later on.
We'll
And I
do.
will send a PDF file to you that has the my presentation, so you can share with the audience. And yeah, give me some time. As you know, I'm a very busy person. Give me some time to arrange a mini seminar, like just 2-3 hours of tinnitus, and hopefully we'll go from there.
Yeah, thank you very much, Professor. That was a great learning experience. I have been one of your students, so I know you very well, and you are one of my favorite professors. I trust you. I like all your publications, all your tuition. I like your honesty and simplicity, and your way of teaching. It was excellent. I came from medical college, but you taught me genetics much, much better than all what I studied in my medical college and in my master's degree. You are one of the best professors I have ever seen, and I have ever learned with them. Thank you very much, Professor, and we will work hard to have an distinguished and exceptional master class on hyperacusis and tinnitus. For the audience, please forgive me for the technical mistake. I don't know what happened, but it seems that the Zoom go to the free account instead of the paid account to allow more people to join. And you can conclude, Professor Ali Danesh. You can give a take-home message for the interested and interactive audience.
Thanks again for your nice words. I'm very humbled, and thank you very much. I hope that this learning community grows, and we can. The ultimate thing is to help our patients, and I'm happy to share whatever I know with you. And one thing that I can tell you is that I have learned to never say no to my patients. So there's always ways to help these patients. And the minimum thing that you can do is just talk to them and counsel them and tell them that, there are ways to train the brain with regard to your tinnitus or hyperacusis or misophonia. When they see that hope, when they receive that hope from you, they actually feel much, much better, and they will function much better. And just good luck with all of your work, and hopefully we'll see you all soon. Thank you and goodbye.
Thank you. Goodbye, Professor. Thank you, everybody, and goodbye.